A 64-year-old male former smoker presents with a 3-month history of progressive shortness of breath, mild hemoptysis, and a dry cough. I am showing you his posteroanterior chest radiograph and an axial chest computed tomography scan. Describe the findings.
The chest radiograph demonstrates a well-defined, wedge-shaped retrocardiac opacity behind the left heart border, which silhouette details and obscures the medial portion of the left hemidiaphragm and the descending thoracic aorta. There is inferomedial displacement of the left hilum, a mild leftward mediastinal shift, and compensatory hyperlucency of the left upper lung zone due to hyperinflation. The axial computed tomography scan confirms a triangular wedge of collapsed lung tissue in the posterior mediastinal recess of the left hemithorax. The computed tomography also reveals a soft tissue density, obstructing the origin of the left lower lobe bronchus. These findings indicate complete left lower lobe atelectasis secondary to a centrally obstructing endobronchial mass, highly suspicious for primary bronchogenic carcinoma.
What are the primary and secondary signs of lobar atelectasis, visible on chest radiography?
The two primary signs of atelectasis are opacification of the collapsed lobe and displacement of the interlobar fissures. The secondary signs represent compensatory mechanisms for volume loss, which include elevation of the ipsilateral hemidiaphragm, mediastinal and tracheal shift toward the side of collapse, displacement of the hilum, compensatory hyperinflation of the adjacent non-collapsed lobes, and crowding of pulmonary vessels in the surrounding parenchyma.
What is the most common mechanism for complete lobar collapse? How do the expected etiologies differ between pediatric and adult populations? And what is the next management step?
The most common mechanism is resorption atelectasis, which occurs secondary to obstruction of a central bronchus. In adults, the primary concern is an obstructing neoplasm, such as bronchogenic carcinoma or carcinoid tumor. In pediatric patients, the most common cause is an aspirated foreign body, while in intubated or post-operative patients, mucus plugging is typical. The next step in management for this adult patient is urgent referral to pulmonology or thoracic surgery for diagnostic and therapeutic flexible bronchoscopy. This will allow direct visualization, tissue biopsy of the endobronchial mass, and relief of the obstruction if possible. I would also recommend a staging computed tomography scan of the chest, abdomen, and pelvis with intravenous contrast.